Hello, I'm Kelsey West, and I'm a PGY1 at Poudre Valley Hospital. Are you ready to take a bite out of acute lymphoblastic leukemia with blinatumomab? I know I am, so let's get started. Here's my disclosure. I have nothing to report. Here are my learning objectives. So at the end of this presentation, you should be able to explain the pathophysiology of acute lymphoblastic leukemia, describe the mechanism of action of blinatumomab, identify the role of blinatumomab in ALL, and develop a therapy and monitoring plan for blinatumomab in an adult patient with ALL. So, what is acute lymphoblastic leukemia? It's a hematologic disease characterized by proliferation of immature lymphoid cells in the bone marrow, blood, and other organs. It's the most common leukemia found in children, but for this presentation, we're going to be focusing on adults, where it makes up about 20% of leukemias in adults. There are three major groups: precursor B-cell, mature B-cell, and T-cell, with B-cell being much more common than T-cell, and precursor B-cell being more aggressive disease than mature B-cell. There is another group, natural killer cell, which is very rare. And it's important to note that treatment strategies will differ by age group. So adolescents and young adults will be treated differently than adults and older adults. Risk factors for ALL include older age, prior exposure to chemotherapy or radiation, and various genetic disorders that I've listed here. For the diagnosis of ALL, patients will present with nonspecific symptoms, including fatigue, fever, weight loss, infections, bruising, and bleeding. They will get blood tests, especially CBC with differential. They will undergo imaging, including a CT, MRI, ultrasound, and echo. And then they will get a bone marrow biopsy, and they will be diagnosed with ALL if it shows greater than or equal to 20% lymphoblasts. Their bone marrow will be further analyzed, where they'll look at the morphology, the immunophenotype, which is really just looking at molecular markers such as CD20, and also cytogenetic analysis using PCR and FISH. And the treatment will vary depending on the type of mutation that is found. Here we have a table showing the cytogenetic changes or mutations that can contribute to adults developing ALL. And there are several here, and I've highlighted the most common, including Philadelphia chromosome and Philadelphia chromosome-like. But we don't have time to get into the specifics of all of these, so this is more for your reference. Here are the prognostic factors which are important to consider when a patient is first diagnosed, and they include white blood cell count, age, time they take to respond to therapy, various mutations, and if they have changes to the number of their chromosomes. Their 5-year survival is about 20 to 40% with the current first-line therapy. So here's my first question, true or false? There's only one mutation that causes ALL. This is false. There are multiple mutations that can contribute to adults developing ALL. Alright, now let's get into our patient case. So NJ is a 57-year-old white male who presented in January to Poudre Valley Hospital after his wife found him unresponsive during the night. 1 week prior to that, he had an unwitnessed fall, but did not go to the hospital. He had a headache ever since the fall that worsened the night he became unresponsive. And upon arrival to the ED, he had a GCS of 3, so he was immediately intubated and sedated. They got vitals, labs, x-ray, and a CT. His vitals were within normal limits. He was afebrile and normotensive. His CBC is very abnormal. He had a very high white blood cell count at 60.5, low hemoglobin 9.7, and a very low platelet count at 18. And the other important thing to note is this other cells absolute, which is very high at 50.2. And the morphology of those other cells were consistent with blasts. His CMP is also here, but nothing concerning to point out. For his imaging, his chest x-ray showed hypoexpansion, but overall normal. His CT showed a subdural hematoma, so he was immediately transferred to MCR for surgery. Here's his past medical history, allergies, and social history. There's nothing too concerning or no risk factors to point out. Here are his home meds, which are pretty standard for a 57-year-old. I did highlight that he did take aspirin at home, which was concerning with his subdural hematoma, and that was immediately discontinued. With his very high white blood cell count and blasts, it was concerning for acute leukemia, so oncology was consulted and they recommended to check his blood with flow cytometry to look for those molecular markers, check a uric acid and a phosphorus, and give supportive transfusions as needed, and also do a bone marrow biopsy when he was stable. So on the 4th day of his hospital admission, he did get a bone marrow biopsy that resulted 9 days later. It showed 90% lymphoblasts, and if you remember from the diagnosis slide, patients need greater than or equal to 20% lymphoblasts to be diagnosed with ALL. So he definitely has ALL. It also showed only 8% mature B cells, which indicates he has precursor B cell ALL, which is more aggressive disease compared to mature B cell ALL. His cytogenetic results are listed here, and it does just look like a mess, but I've highlighted the T922 mutation, which indicates he's Philadelphia chromosome positive. He also has this 14q32 rearrangement, which is found in a small percentage of B-cell ALL and is associated with an unfavorable prognosis. His molecular markers showed that all of his cells were CD19 positive, partially CD20 positive, and that's likely due to the 8% mature B cells because only mature B cells have CD20 on their surface. He's also CD33 negative. So for his overall diagnosis, he has Philadelphia chromosome positive precursor B cell ALL. So how are we going to treat him now that we know what his diagnosis is? Let's get into the NCCN guidelines that for acute lymphoblastic leukemia, where the goal of treatment is cure. And how we get patients to cure is we give them treatment to remove all signs of their disease so that they can get a stem cell transplant. Here's the workup for ALL patients, and I just want you to focus on the right side, which shows how the treatment will vary based on if a patient is Philadelphia chromosome positive or negative and based on their age. So our patient is 57 years old and he's Philadelphia positive, so we will go into this treatment algorithm. But before we do, let's talk about what being Philadelphia chromosome positive actually means. So it's a translocation where the BCR gene translocates next to the ABL gene to create a whole new gene called the BCR-ABL gene. And this BCR-ABL gene is able to be transcribed and translated into a protein, the BCR-ABL protein, which is a kinase. And we know kinases are activators within cells. So this brand new BCR-ABL protein activates various pathways within cells to promote proliferation and survival of lymphoid cells. And this is one of the causes of ALL. So here's my second question. How are treatment options determined in ALL patients? Philadelphia chromosome positive or negative, CD19 positive or negative, by their age, white blood cell count, both A and C, or all of the above? And the answer is both A and C. So we look at their Philadelphia chromosome status and their age. All right, so back to our algorithm. Our patient is less than 65 years old without substantial comorbidities, so his treatment options include a clinical trial or TKI plus chemotherapy or TKI plus corticosteroids. And if you look next to chemotherapy, there's a superscript of an R, which is where we're going next, to see the recommended chemotherapy regimens. So all of the first-line regimens include a TKI plus cytotoxic chemotherapy. 80% of patients will achieve complete clinical remission on these regimens, but 50% will relapse with chemo-resistant disease. So for our patient, he was planned to start on the first option of hyper-CVAD plus dasatinib, which dasatinib is one of the 3 TKIs that are recommended. So let's just take a moment and discuss these 3 TKI options. They are imatinib, dasatinib, and ponatinib, and all three of these inhibit the BCR-ABL protein, and they've all been studied with hyper-CVAD. So the first one that was developed was imatinib, and patients did relapse on imatinib, which prompted the development of dasatinib, which has higher selectivity and potency, and it also has higher blood-brain barrier penetration, which is important because the CNS is a common site for relapse in ALL patients. But patients still relapsed on dasatinib, and when they looked at the studies, they found that 75% of patients who relapsed had a specific mutation called the T315I mutation, and that's where ponatinib comes in. So ponatinib targets this specific mutation, but it can also be used in patients without the mutation. And when it was studied with hyper-CVAD, it did show a higher 5-year overall survival rate compared to the previous generation TKIs. And very recently, a meta-analysis showed that it was more efficacious than the other TKIs as first-line therapy. But since this is so new, it hasn't gotten into the guidelines yet, so all three of these are still recommended as first line. Okay, so back to our patient case. So NJ was started in January on hyper-CVAD with 8 cycles planned. They also wanted to start dasatinib, but it needed a prior authorization because they wanted him to try imatinib first. So they applied for free drug from the manufacturer, and that was approved. So in February, he did start on dasatinib. And then in June, he had to stop his hyper-CVAD after 7 cycles because he was having increased toxicity. He was having a lot of fatigue and balance issues. So if you recall, he did have a subdural hematoma from a fall when he was initially diagnosed. And throughout his whole CVAD, hyper-CVAD treatment, he kept having falls. So in July, he had a bone marrow biopsy that showed 0.39% abnormal or immature B cells by flow cytometry, which indicates he has minimal residual disease. So what does that mean? So minimal residual disease is routinely tested for in patients with ALL. It's submicroscopic disease that persists in the bone marrow. So these patients don't have any signs or symptoms of disease, but they will eventually relapse. And studies show 94% of patients with minimal residual disease will relapse after induction despite continued chemo. It's detected by flow cytometry or PCR, and it really depends on what the cytogenetics were at diagnosis. For example, if a patient is Philadelphia chromosome positive, you can use BCR-ABL by PCR to test for minimal residual disease. And the definition of MRD is if the PCR or flow cytometry shows greater than 0.01% abnormal B cells. And our patient had 0.39% abnormal B cells. So he does have minimal residual disease. So where are we going to go next with his treatment? Let's go back to our treatment algorithm. So we started him on a TKI plus chemotherapy. We assessed his response with a bone marrow biopsy, and because he had minimal residual disease, he had less than a complete response. So he has refractory disease. So we will go into this treatment algorithm next. So this is split between patients that are Philadelphia chromosome positive and negative, so we will go along the top. And the next step is this mutation testing, which is really just retesting for changes in cytogenetics to see if we need to change his dasatinib to something like ponatinib. But his cytogenetics didn't change, so we just continue on. And so our next choices include Blinatumomab, which is what we're going to talk about next. Alright, so Blincyto or Blinatumomab was FDA approved in 2014. It's manufactured by Amgen, and it costs close to $130,000 per cycle. So it is not a cheap drug. It has 2 indications for adults and children with precursor B-cell ALL, either in their first or second complete remission with minimal residual disease, or relapse refractory ALL. So Blincyto has a pretty unique mechanism of action, and it's also unique because it's a completely bioengineered molecule. It's a bispecific CD19-directed CD3 T-cell engager, or a BiTE, and it binds to CD19 on B cells and CD3 on T cells and hooks them together. So why did they decide to target CD19? Well, it's expressed on even the earliest B cell precursors and mature B cells, in comparison to something like CD20, which is only found in mature B cells. So this becomes important, especially in patients like ours, where he has mostly precursor disease. And this results in Blincyto having the ability to seek out those persisting cancer cells in the bone marrow. So back to the mechanism. When Blincyto connects the T cell to the B cell, it activates the T cell and forms a synapse between the two cells. The T cell produces perforin molecules, which create pores in the B cell that let in cytolytic proteins and inflammatory cytokines, which results in the lysis of the B cells, cancerous B cells. Now I'm going to go over 3 important clinical trials for Blincyto that are relevant to our patient case. The first being the TOWER study, which was the major study that led to the approval of Blincyto in patients with relapsed refractory precursor B-cell ALL, which is applicable to our patient because he has refractory disease. Although the study excluded Philadelphia chromosome-positive patients, which is a limitation. But this is one of the largest studies of Blincyto, and it compared Blincyto to the standard of care. It is also important because the FDA granted accelerated approval of Blincyto based on the early results of this study in 2014, and the approval was contingent upon the finalized overall survival results that weren't published until 2017. And the results showed that Blincyto did improve overall survival compared to the standard of care, and it also improved complete remission rates. And of the patients with complete remission, more achieved minimal residual disease negative status when given Blincyto. Now, the next 2 trials were much smaller, but they provided evidence for using Blincyto in patients with minimal residual disease, which is the TOP study done in 2011, and Philadelphia chromosome-positive patients, which is the Martinelli study done in 2017. Both studies were single-arm, but a major difference was that the TOP study allowed Philadelphia chromosome-positive patients to continue their TKI therapy, while the Martinelli study did not and only allowed Blincyto as monotherapy. The TOP study showed that 80% of patients became minimal residual disease negative. They had a whopping 5 Philadelphia chromosome-positive patients in their study, either on imatinib or dasatinib, and 3 out of the 5 became MRD negative, which gives a little evidence for Blincyto with a TKI. And then the Martinelli study showed that 36% of patients achieved complete remission during the first 2 cycles, and the relapse-free survival was 6.7 months. So altogether, these 3 trials provide evidence for using Blincyto in our patient, because NJ has refractory disease, he's Philadelphia chromosome positive, and has minimal residual disease. Okay, so here's our third question. Which receptors does Blinatumomab bind to? CD33 and CD20, CD3 and CD19, BCR-ABL and CD19, or none of the above? And the answer is CD3 and CD19. Alright, so now let's get into the dosing for Blincyto. For the induction and consolidation cycles, Blincyto is given as a 4-week continuous infusion followed by 2 weeks off. So the total cycle is 6 weeks. And in order for patients to get 4 weeks of continuous infusion, they're usually discharged with a CAD pump. And then for the dosing, it really depends on the indication and the patient's weight. So for the first indication of patients with minimal residual disease, they get 1 induction cycle followed by up to 3 additional cycles for consolidation. So patients that are greater than or equal to 45 kilos will get a fixed dose of 28 micrograms per day. Patients less than 45 kilos will get a dose based on body surface area at 15 micrograms per meter squared per day with a max of 28. And then for patients with relapsed or refractory B-cell ALL, they get 2 induction cycles followed by 3 additional consolidation cycles and then up to 4 additional cycles of continued therapy. And for the continued therapy cycles, patients still get 4 weeks of Blincyto as a continuous infusion, but they're followed by 8 weeks off instead of 2. So these cycles are 12 weeks long total. And the only difference between this dosing and the previous dosing for minimal residual disease is the first induction cycle, where patients get a reduced dose for the first 7 days. But it's still based on weight, so patients greater than or equal to 45 kilos still get a fixed dose, but it's reduced to 9 micrograms per day for the first 7 days, and then it goes up to the 28. And patients less than 45 kilos still get a dose based on body surface area, and they get a reduced dose at 5 micrograms per meter squared per day for the first 7 days, and then it goes up to the 15. And then for the other cycles, it's the same dosing as for minimal residual disease. Here is an example of what the beacon plan looks like for a patient that's getting 28 micrograms of Blincyto per day. And at the top, you can see it says Blinatumomab 32.5 micrograms, and this seems inappropriate because the max dose is 28 micrograms. But if you look in the comments where I've highlighted, you can see that this will deliver 28 micrograms over 24 hours because this is a continuous infusion. And that brings us to some unique preparation and administration requirements for Blincyto. But for the sake of time, I've prepared an additional handout that provides much more details for this. But I'm just going to highlight the most important ones. So it's important to know that Blincyto is not a hazardous drug, so it does not have to be made in the chemo room. It comes as a kit with a stabilizing solution. You should only use non-PVC materials. You should filter it and use a spinning spiros. And you should prime the tubing with drug and not saline. And then during the preparation, 3 checks by a pharmacist are required. And then for administration, it's administered as a constant rate with a dedicated lumen, and you should never flush the line because this can give patients too much of the drug and can cause adverse effects. And you should not stop the infusion for labs. You should draw labs at a separate lumen or site, except if blood cultures are needed. And there's more details about that in the additional handout. So now we're going to get into some monitoring parameters, with the first being neutropenia, leukopenia. So these patients are at very high risk of infection. And infection was the most common reason that Blincyto was discontinued in the trials. So for the management of this, we will give patients bacterial, viral, and fungal prophylaxis, and also granulocyte colony stimulating factors if needed. And these patients are also at high risk for tumor lysis syndrome, so we will manage this by giving them hydration, allopurinol or respiricase if needed, and phosphate binders. The emetic risk for Blincyto is minimal, so breakthrough antiemetics are only recommended. Alright, now let's get into a couple more unique toxicities to watch out for when using Blincyto. And one of them is neurological toxicity, which occurs in 65% of patients. So the symptoms include tremor, slurred speech, confusion, and the others I've listed here. The onset is about 7 days from the start of infusion. And to manage this, you really need to do an extensive baseline neuroexam to be able to check for changes in the patients. You also need to do CTs of the head to check for bleeding if they have acute changes. And the good thing about this is that it usually resolves with interruption of the infusion. And then if needed, you can also use anti-seizure medications like Keppra. Another toxicity to look out for is cytokine release syndrome, which happens in 15% of relapse refractory patients and 7% of patients with minimal residual disease. And the symptoms include fever, chills, headache, and the others I've listed. And the onset is about 2 days from the start of infusion, so a little bit sooner than the neurological toxicity. And for the management of this, we need to pre-medicate patients with steroids, either prednisone or dexamethasone, 1 hour before the start of infusion. And if they get this with a grade 3 or higher, you should stop the infusion. And also in the studies, for some patients with high tumor burden, they did a debulking regimen with dexamethasone before they started Blincyto. They weren't very clear about how long to give the dexamethasone or how many days before Blincyto this was given, but it's just something to keep in mind. There's also another drug called tocilizumab, which is an IL-6R antagonist, and this must be kept on hand for severe or life-threatening cytokine release syndrome, and the dosing is here for your reference. So going back to our patient case, for NJ, we were monitoring for cytokine release syndrome, and we did pre-medicate with dexamethasone before his infusion. For the neurological toxicity, he did have baseline deficits from his subdural hematoma, so we were doing extensive neuroexams, and he got multiple CT scans to monitor his subdural hematoma, and because he was falling and he continued to have low platelets. He was also on Keppra ever since he had the subdural hematoma. And then we also monitored his CBC and gave him transfusions as needed. So in August, he got his first cycle of Blincyto at Presbyterian St. Luke's, and then he had a bone marrow biopsy that showed he was MRD negative and also BCR-ABL negative, which is great. So it shows that the Blincyto worked. And then in October, he started his second cycle of Blincyto at Poudre Valley Hospital, his consolidation cycle, and that's where I saw him. And he was discharged from the hospital on the third day of Blincyto with a CAD pump. His latest office visit showed that he did have increased toxicity. He's been having a lot of fatigue, diarrhea, and balance issues. As I've said throughout the presentation, he is continuing to fall. So the Blinatumomab infusion was stopped and held on day 16, but they are planning to restart it. He has continued on dasatinib for now, and his future goal is still to get a transplant, and they are currently looking for a donor. So here is my final question. What was the main reason NJ was given dexamethasone before his Blinatumomab infusion? Was it because he was BCR-ABL positive to reduce nausea, as Blinatumomab has high emetic risk, to improve neurological toxicity, or was it to reduce the risk of cytokine release syndrome? And the answer is D. We gave him dexamethasone to reduce the risk of cytokine release syndrome. To wrap up, let's talk about some future directions for ALL. Ponatinib and Blinatumomab have greatly improved the long-term survival of these patients, and it's likely that Ponatinib and Blinatumomab will become first-line therapy. Additional targeted therapies will continue to be developed and further improve the survival of these patients. There are also a lot of clinical trials that are in progress. There's one looking at Blincyto plus hyper-CVAD as first-line therapy, and there's others that are looking at patients who are CD20 positive and using drugs like rituximab or blinatumomab. But at this point, we don't know which ones to use or which patients would benefit the most, or if we should always use them. There are also studies looking at the PD-1 inhibitors that would theoretically improve the T-cell response, where when Blincyto connects the B cells and the T cells together, if we could theoretically take the brakes off the T cells, could we improve the efficacy of Blincyto? So these are just some things to watch out for in the future. Please feel free to reach out to me with any questions you have. Thank you.